Hello, I'm Alex Prat, and before I begin, I would like to thank Professor Hesham and all the scientific committee for inviting me. It is an honor, a pleasure to be here today, and unfortunately, I cannot be there in person, but hopefully next year we can all meet together and interact. So I hope things get better for everybody. So in less than 20 minutes, I will go over this particular topic, which is trying to use biology-based data to either predict prognosis or treatment benefit in terms of CDK4 and 6 inhibitors in hormone receptor-positive, HER2-negative breast cancer. These are my disclosures. So on one hand, in the last decade, we have learned a lot about intrinsic biology, subtyping in hormone receptor positive, HER2 negative primary disease. This is now data with over 9,000 patients showing the distribution of the different subtypes. And again, the luminal A, luminal B subtypes predominate as expected, and a few non-luminals, most importantly, the HER2-enriched and the basal-likes representing between 2 to 6% of the patients. However, in the last few years, we've learned much more about what happens in the advanced metastatic setting in hormone receptor positive HER2 negative disease. And in this particular context, we now have several studies showing that we can identify also the luminal A and the luminal B subtypes, although the luminal A's are less in the advanced disease than in early disease. But most importantly, what we see is that there is a substantial proportion of patients with non-luminal disease in the advanced setting, specifically the HER2-enriched subtype, despite all these tumors being hormone receptor positive, HER2 negative breast cancer. In this particular study that we published in 2017, was one of the first studies looking at pair biopsies between primary disease and metastatic disease, and showing the subtype changes, which occurred in around 37% of the cases. So in 1 out of 3 patients, subtype changed. And this was especially true in primary luminal A tumors, whose relapse was basically non-luminal A in more than 50% of the cases, mostly luminal Bs, and around 10 to 15% of patients with primary luminal A, luminal Bs, the subtype changed to HER2-enriched, despite, again, all these tumors being HER2-negative breast cancer. On the other hand, tumors like basal-like or HER2-enriched, the vast majority, more than 75% of the cases, they remain basal-like or HER2-enriched in the metastatic site. So I would conclude that around luminal disease is the one that changes the most in the metastatic setting. In particular, luminal A becomes non-luminal A in more than 50% of the cases in the advanced setting. So again, this was a biological description, but what about the relationship between intrinsic biology within hormone receptor positive HER2 negative disease in the advanced setting and outcome? This is data we published in 2016 in JAMA Oncology in a study of patients who participated in a phase 3 clinical trial of letrozole plus minus lapatinib. Here's the subset of patients with hormone receptor positive HER2 negative, showing that intrinsic subtypes are highly prognostic. The luminal A's do better compared to luminal B's, and then the non-luminal, and in particular the basals and the HER2 enriched with letrozole only, did very poorly in terms of PFS, but also in terms, as you can see here, overall survival. This was confirmed in the Bolero-2 study with less samples, 261, showing also in terms of PFS and also overall survival than the non-HER2 enriched, and here the vast majority were HER2 enriched, did much poorly compared to the non-HER2 enriched. And in the Bolero-2, there were no differences between luminal A and luminal B. So definitely the HER2 enriched needs attention. It's a substantial proportion of patients, and they have a very poor outcome with letrozole or with endocrine therapy only. Importantly, in these 2 studies, 80% of the samples were profiled from the primary tumor, not the metastatic site. So even profiling primary tumors allows us to predict prognosis in the advanced setting. Another piece of data is this one. What we observed is that intrinsic biology is prognostic as expected and independently of classical clinical pathological variables, such as if the patient received prior endocrine therapy, the number of metastases, the performance status. However, at the end of the day, several of these variables predict prognosis independently. Definitely subtype predicts, but as well as prior endocrine therapy, performance status, number of metastases also provide independent prognostic information. So if we are to predict prognosis in the advanced hormone receptor positive HER2 negative disease, we will have to integrate many of these data types all together to better predict prognosis, because again, each one of these provide additional prognostic value. And this is actually what we did last year. We tried to combine many of these variables into a single score, a single assay. This is what we call the PAM50-MET assay. This has been recently published in Clinical Cancer Research. This is a model that integrates several variables. Subtype is there, individual genes, performance status, age, number of metastases, and type of biopsy. And this model was trained to predict prognosis in the EGF 3008 trial, the one I showed you before, letrozole plus minus lapatinib. And it was trained to predict progression-free survival, but in this context, it also predicted overall survival. And then this model was tested, blinded in the Bolero-2, 267 samples, and also there it predicted PFS and also overall survival. So here we have a tool that potentially could allow us to identify patients that with endocrine therapy only might do well in terms of PFS and overall survival. So it could be a tool that could help us escalate or de-escalate therapy in the advanced setting. Of course, more validation is needed. Interestingly, the prognostic value of intrinsic subtypes has been evaluated also in the PALOMA-2 study, showing that clearly the luminal A's do better than the luminal B's in terms of median PFS. Interestingly, here in PALOMA-2, one could look at prediction of benefit, in this case to palbociclib on top of endocrine therapy, on top of letrozole. And here clearly the benefit was mostly restricted in the luminal A's, luminal B subtypes. In the HER2-enriched, despite the low number of patients, there seems to be no benefit to palbociclib in this particular study. The median increase in PFS was less than 3 months. Again, retrospective data, ad hoc, exploratory data, but suggesting this particular observation. Recently, I reported at San Antonio a large analysis, more than 1,000 patients across the Mona Lisa 2, Mona Lisa 3, Mona Lisa 7, looking at the trials of endocrine therapy plus minus ribociclib. And we did perform intrinsic subtyping, and we confirmed the poor prognosis of HER2-enriched and basal-like with endocrine therapy only. We also confirmed the benefit of ribociclib in luminal A's, luminal B's. And interestingly, what we observe is that in the HER2-enriched, despite the poor outcome with endocrine therapy only, in the placebo arm, this subtype benefited substantially, actually benefited the most from ribociclib compared to the other studies. So there seems to be high activity of ribociclib in this particular subtype, something that we did not expect. So definitely a first step is to try to characterize the metastatic setting or metastatic tumors that are hormone receptor positive, HER2 negative. But this is not enough. We probably need to better understand the tumor evolution in the metastatic setting. So additional biopsies, especially upon progression to CDK4/6 inhibition, is needed. This is ongoing work. We don't have much data reported out there at the tumor level. This is our own data, and now we have more than 20 patients, but here you see 17, where we are seeing that the frequency of HER2-enriched subtype is even increased, I would say, in the context of resistant tumors to CDK4/6 inhibition and endocrine therapy. So definitely this subtype, its proportion seems to keep increasing. So definitely strategies, treatment strategies in this context are needed. So we need to understand really what these tumors are and how we can treat them. Another aspect that I wanted to highlight is the potential value of ctDNAs, of liquid biopsy, to monitor disease and in particular to predict benefit to CDK4/6 inhibition in the advanced setting. This is a tool that is becoming more and more popular, not only to identify mutations, but also to identify or quantify the quantity of tumor DNA in plasma as a surrogate of the efficacy of treatments. In this line of research, we have this study we presented at ESMO Breast last year, and it's going to be published next month. It's in press in NPG breast cancer. This is a pilot study that we did at our hospital. We collected plasma samples at baseline and after one cycle, so before starting cycle 2 of a therapy consisting of endocrine therapy and CDK4 and 6 inhibition. It was a pilot study of only 45 patients with these paired samples where we had long follow-up. And what we observed is that ctDNA can be detected in more than 80% of the patients at baseline. But most importantly, what we observe is that there are substantial changes in ctDNA levels at 3-4 weeks of therapy. So here you can see in section A, the changes of individual mutations detected at baseline versus cycle 2 day 1. Some mutations increase the quantity, its concentration. Some others decrease. The vast majority decrease, but some increase. So we can now take a BAF ratio, a variant allele frequency ratio for each patient as a measure of how much they are benefiting from CDK4 and 6 inhibition. So here you see that around 38% of the patients, the ctDNA actually increased, relatively speaking. Some 28% decreased substantially, and in 1 out of 3 patients, the decrease was extraordinary, more than 70% of ctDNA decrease at 3-4 weeks of therapy. What we observed is that these relative changes between baseline and cycle 2 day 1 are associated with progression-free survival. So clearly those patients in red who have a relative increase in ctDNA do much worse. They will progress quite fast to endocrine therapy and CDK4 and 6 inhibition, whereas those that have a relative decrease in ctDNA, especially those that have a very good response in ctDNA, and do much better. So here you have we have a tool that could be an early readout of how the patient is doing on these particular therapies, and this tool should allow us to design future clinical trials where we use ctDNA to guide the therapy and show that treating before progression, treating when we detect increases in ctDNA could improve outcomes compared to the standard of care, for example. And finally, another aspect is early disease, where I do believe we need to learn more about the biology of tumors treated with CDK4 and 6 inhibition endocrine therapy. I think the era where we are running large trials with thousands of patients, heterogeneous population of hormone receptor positive HER2 negative disease, and randomizing them to one treatment strategy versus another one should be over, or at least should be done in a more rationalized way using biology-based data. I think examples such as the PALAS trial clearly tell us that. This is a study that we published last year, the Coraline trial, a neoadjuvant trial trying to study the biology induced by CDK4/6 inhibition. This is a study where we selected patients prospectively that were postmenopausal, hormone receptor positive HER2 negative, stage 1 up to 3A, tumors of 2 centimeters or more, and they had to be luminal B by gene expression profiling. So we made sure these tumors were highly proliferative and were high risk in more than 90% of the cases. These patients were randomized 1-to-1 to standard chemo, 6 months of anthracycline taxane-based chemotherapy versus letrozole ribociclib. And we had a biopsy at baseline, at day 15, and at surgery. Importantly, we performed gene expression analysis across the 3 time points to try to study the biological changes induced by both treatment arms. And the primary endpoint at surgery was the proportion of patients that went from being high risk at baseline to being low risk at surgery, defined by the PAM50 risk of relapse, which integrates biology, tumor size, and nodal status into a single score. These are the clinical pathological characteristics. So more than 100 patients were randomized 1-to-1 The vast majority had T2 tumors. Around 40% of the patients had clinically not positive disease at baseline. The median Ki67 was high, 30 to 35%. The median risk of relapse was high, more than 60, 77, 70%. And you can see the risk of relapse in 90% of the cases, it was high risk in both treatment, arms. So this is definitely a population that I think we all would agree that they need chemotherapy. These are the responses. So each bar is a patient, and here you have the relative changes, the absolute changes actually of risk of relapse between baseline and surgery. And you can see that in general, the two arms look quite similar. The proportion of ROR low disease at surgery was very similar. The estimate was very similar in both arms. And in general, you can see that it was quite similar, thus suggesting that biologically speaking, ribociclib and endocrine therapy seem to achieve similar outcomes as a standard multi-agent chemotherapy. And the question then is, what's next? Definitely, this study of 100 patients doesn't change clinical practice, but I do believe it opens doors. I think the community, in some aspects, is starting to get ready to try to decrease the amount of chemo or even avoid chemo in selected patients in this context of a very good response to neoadjuvant endocrine-based therapy. This is our own data from Coraline. The study ended at surgery, so the physicians, the patients could decide what to do after surgery. If the patient received ribociclib in the neoadjuvant setting, they could give chemotherapy. And this is what happened. To us, it was quite surprising to see that in the ribociclib arm, after surgery, only 48% of the patients received chemotherapy. So 52% did not receive any chemotherapy and continued with just endocrine therapy. As expected, this decision was related to the type of response at surgery. So those patients that had a very nice response to endocrine-based therapy in the neoadjuvant setting and had either ROR low disease or PEPI score of 0, the physicians, the patients did not recommend a chemotherapy, whereas those tumors that did not really respond, had high Ki67 at surgery, those in general, chemotherapy was indicated. But I do think this tells us that there is somehow some sense that chemotherapy could be avoided in selected patients. And this is actually what we would like to test prospectively, and hopefully this trial will be a reality next year. This is an effort between Unicancer and Solti. It's a study much larger, 530 patients, pre and postmenopausal, with high-risk tumors, luminal Bs and HER2-enriched. These patients will be treated for 6 months, just like Coraline, with letrozole and ribociclib. And at surgery, those that achieve a very nice response, defined as ROR low disease, these patients will not receive chemo, and endocrine therapy and ribociclib will be continued up to 3 years. Whereas those patients that do not achieve ROR low disease at surgery, chemotherapy will be indicated, and they also will continue with ribociclib up to 3 years. So this is a study that it's meant to provide some survival data, showing that this strategy of using the neoadjuvant setting to de-escalate chemotherapy could be of value in the future. So to end, these are my take-home messages. On one hand, I do think that we need to use in the future biology-based data to better tailor therapy in hormone receptor positive HER2 negative disease in the advanced setting, but also in early disease. That we have this subtype, the HER2-enriched, that is infrequent in early disease, but is quite frequent in the metastatic setting, has poor outcome with endocrine therapy and needs attention because it's a poor prognostic feature. Ribociclib is showing a very high activity in the Mona Lisa program in this group of patients, as well as in luminal Bs, both in the advanced setting as well as in early disease in the Coraline trial. I do believe that we need to start thinking about integrating biomarkers, not only looking at a single biomarker, trying to combine clinical data with genomics to predict and respond and answer particular clinical questions of relevance, both in early and the advanced disease. And I think today we have the technology and the tools to do that. The neoadjuvant setting, I do believe, is of importance as it is for triple negative and HER2 positive disease. It is for hormone receptor positive HER2 negative. The tumor's biology during and after therapy are telling us a lot, telling us a lot about the future, the prognosis of the patients. And we should be using that strategy to design a next generation of trials to either escalate or de-escalate therapy. And I think this is also something to focus. With that, I will end by thanking all our collaborators as well as my funding sources. Thank you very much.